ask any questions that you may have that you haven't had a chance to ask at the doctor's office. So I think they have a microphone or somebody that you go ahead and ask your question and we'd be happy to answer them. So the question's about the progression of Parkinson's disease. And Parkinson's is a very slowly progressive disease. So it's not something that happens very quickly over days or weeks. If for some reason you had a change in symptoms that happened very quickly, like over a weekend or something, then it's important to check other things like an infection, do you have a UTI, do you have a flu, is there something like a stroke going on? Because usually Parkinson's disease is a very slowly progressive disease. And with the medications, we can do a pretty good job of keeping up with the symptoms to sort of keep that at a nice slow plateau. So by the time you see the neurologist at the office for a tremor, rigidity, or trouble with gait and balance, you actually have already had Parkinson's 10 to 15 years. So it takes about 60 to 70% cell loss to develop the motor symptoms of Parkinson's. So it's been going on for a very long time, and that kind of gives you an idea of how slowly progressive the disease is. So today, with the medicines, both medical and surgical, that we have for the treatment of Parkinson's disease, Parkinson's is a chronic disease, something that you live with. It's no longer a disease that you die from. So if there's any change that happens very quickly, then many times we'll look for other reasons. Number one is usually an infection.
So I read a lot about people suffering from complications of Parkinson's. So what exactly does that mean?
So the question is about the complications of Parkinson's disease. Remember that the medicines only treat your motor symptoms of the Parkinson's, so things like tremor, rigidity, bradykinesia, which means slowness of movement, and the gait and balance. But you have a whole host of non-motor symptoms of Parkinson's disease, and that's everything from constipation to low blood pressure, bladder issues, things like anxiety and depression, and cognitive issues. And many times, because the medicines actually make those symptoms worse rather than better, we have more trouble. So if the patients become demented, one, they can't tolerate the medicines very well, and we have to pull back on the medicines and give up some mobility to keep the mind as clear as possible. And the two things that gets us into trouble with Parkinson's are falls that lead to broken bones, and swallowing issues that lead to choking or aspiration pneumonia. And the less of the medicine that we're able to use, the more of those troubles that we have. So usually the complications, the reasons patients end up in a nursing home is usually dementia, when they can no longer take care of their own activities of daily living, administer the medications. So that's probably the most common complication. But what we try to prevent are falls, either from freezing of gait or from low blood pressure, and any swallowing issues that lead to choking or aspiration pneumonia, where the food goes down the wrong pipe. So many times you'll see in obituaries, patient died of Parkinson's disease. They actually didn't die from Parkinson's, they died of something else. So they had pneumonia, or they developed dementia, or became septic, or something like that. So the question is about the medication and how does one determine the proper dosage? And everybody's different, and everybody responds to medicine is different. So it's done by trial and error. We start the medicine and then we either go up or down depending on what your side effects and the benefit of the medicine is to you. Remember that the medicines are purely symptomatic, so we never want you to feel worse on the medicine than you do with the actual disease. If the tremor doesn't bother you, we don't need to increase the medicine make you dizzy and nauseous and make you hallucinate if the tremor didn't bother you in the beginning. And everybody's different. Some people tolerate 300 milligrams of levodopa just fine, and some people can tolerate up to 3,000 milligrams of levodopa. So everybody is different, and everybody tolerates a slightly different cocktail of medicines. So just because your neighbor's taking Mirapax and amantadine and Cinemet, that may not be the right cocktail for you. You may not be able to tolerate that cocktail. So everybody's different, and everybody's response is different. And then as the disease progresses, we slowly titrate the medicine up or down depending on what your symptoms are.
Can you take too much?
So the question is, can you take too much? So it turns out that Parkinson's medicine is very forgiving. Too little medicine, you're slow, stiff, and rigid. Too much medicine, you're dyskinetic or wiggly, and you can get confused or hallucinate, but that all goes away once the pill's metabolized. So we don't get too exercised if you accidentally forgot a dose or took an extra dose, because once the pill's metabolized, that dyskinesia, the confusion will go away. So it's not like insulin or heart medicine that we don't want you to either forget it or accidentally take an extra dose. So that's why many times your neurologist will let you play around with your dose of Cinemet and take a half here or quarter there, depending on how much you need. Remember that we're treating your body, not the clock. So if you're on medicine every 3 hours, but you ran out of medicine after 2 hours, you're slow, stiff, and rigid. We want to take the Cinemet at the 2-hour mark when you're wearing off, because it turns out that the longer you wait to take the next dose of medicine, the longer it takes to kick in. So that we're treating you, the body, not the clock. And that Cinemet, it works like gas in the car. So if you drive your car at 80 miles an hour, you're going to use up more gas than if you drive at 50 miles an hour. And that's why you notice that some days the medicine lasts longer than others. Some days you're doing more activities and you're using it up faster, and some days you're sitting at home watching a ball game and it's going to last longer. So that we want to treat you, your body, not the clock. And so that we're a little bit more flexible in taking the medicine.
I have a question about sleep problems. My husband is seeing a sleep specialist. He's been on the CPAP machine for over a year. The doctor has said that he has to be on it a longer period of time before he can take a medicine in the daytime to help him stay awake in the daytime. And I don't understand why we have to keep waiting to take something that would help.
So the medicine's about sleep apnea and using the CPAP machine, and then medicines like Adderall or Ritalin or Strattera, Provigil, that keep you up at night, during the day. So sleep apnea is very common in Parkinson's disease. It's one of the reasons why you can't sleep through the night. And so then we use a CPAP machine to keep oxygenating the brain. Because the medicines that keep you up during the day, like Provigil, are a scheduled drug by the DEA. It's basically amphetamines. And so we can't just keep prescribing them to patients and give you a 3-month supply. It's done in 30-day increments, and it's a scheduled drug. And so that there are rules on how and when you prescribe the drugs, and so that we have to show that now, even though the patient is sleeping through the night and using their CPAP machine, they're still sleeping during the day, therefore they need this drug. So it's just that you have to prove to the insurance company, and to the DEA that there's a medical reason for the doctor to be prescribing amphetamines.
How long do you have to wait before you can get the
It depends on the insurance company. So some insurance companies it's 30 days, some it's 60 days, it all depends.
We've been at it for over a year.
Oh, well, I don't know. I would talk to your doctor and insurance company.
Would you repeat each question? I'm not familiar with the...
I have a mic, and I can try, but I don't know if I'm that fast. Let's see if the mic works.
It's my understanding.
No. Testing. Sorry.
Go ahead and we'll repeat the question.
Over here.
It's my understanding that carbidopa initially works, and then after a period of time it loses its effectiveness. Some doctors prescribe it initially, others don't. I'm just wondering what your position is on that, and whether you prescribe it initially or not.
So the question is, do you become tolerant or habituate to Sinemet or levodopa? The answer is no. So the reason that you start taking the medicine 1 tablet 3 times a day and then 10 years later you're taking it 6 or 7 times a day is not because the medicine, the body's become used to the medicine, is that we need to replace more of the dopamine through the medication because you're making less and less of your own dopamine, and so we have to replace it. So remember, you're seen by the neurologist and you've got about 40% of those cells that produce dopamine still working. And as the disease progresses and the time goes by, that pool of dopamine-producing cells goes to 30, 20, 10%. And as it goes lower and lower, then we have to replace more of the dopamine through the medication. Because remember, your Sinemet, it's carbidopa, levodopa, and that levodopa turns into dopamine in the brain. So it's not that your body has become tolerant or habituated like it does to opiates. You just need to replace more of it. But we know that long-term use in high doses of levodopa can cause dyskinesia, or the wiggly movements. And so many times we will start once-a-day medicines like Mirapex ER or Riquepexel or Nupro, or extend the life of your Sinemet with Azelect or Selegiline to stretch it out, because we know that pulsatile nature of giving you the Sinemet 3, 4, 5 times a day makes the receptors kind of irritable and leads to the dyskinesia and the on and off. So that we want to give you medicine the way the normal brain gives you dopamine. It gives you continuous dopamine tone over the 24-hour period. It doesn't pulse it doesn't go peak and trough 3 or 4 times a day. So many times we will start patients as their initial therapy with a once-a-day medicine. 1, because it's easier to take a medicine once a day, and 2, because it avoids the peaks and troughs of taking Sinemet 3 times a day, and then add in the other drugs as we need them. If you don't tolerate the dopamine agonist, so it gives you nausea, it makes you dizzy, it makes you hallucinate, or if you're a fall risk, or if you have a tremor we can't treat with the other agonists, then we'll start Sinemet right away. So it all depends on the patient. So, it all depends on, how old they are they still working, are they commuting, with what medicines we start first. So you can start it earlier or later, but the reason many times we started later is to avoid the peaks and troughs that you get taking a medicine multiple times a day.
What do you tell your patients about frequent falls?
So the question is, what do you tell patients who have frequent falls? So falls are very common in Parkinson's disease. It's one of the cardinal features of Parkinson's. And when we want to figure out why is the patient falling? Are you having freezing of gait and then you're frozen and then you fall over? Are you getting dizzy and then you faint and fall over? So we want to figure out why that is and fix that. So if it's orthostasis, if it's low blood pressure, and every time you stand up you get dizzy and woozy, then we can fix that by adding fluids, increasing salt in your diet. If we need to, we can use Midodrine or Florinef or Northera to artificially keep the blood pressure up. We eliminate blood pressure medicines or bladder medicines that can cause a drop of blood pressure. If you're having freezing of gait, we can do physical therapy or some exercises for freezing of gait. We can use a laser line on a U-step walker. So we try to eliminate as many causes for falls as we can. Because again, remember, that's one of the reasons that we get into trouble are falls that lead to broken bones. So we want to look at the whole panel of medicines, what you're taking, and eliminate medicines that can make you dizzy and faint or lower the blood pressure and improve your freezing of gait. But Parkinson's patients tend to be retropulsive, so you can't step backwards and catch your balance. So using a walker, walking sticks, all of those helps you with the balance. Doing the big and loud.
Regarding fascination, wants to know if the falling has to do with lungs. He has fascination, and he's trying to figure out how to overcome that.
So fascination means it's like when you take short little steps and they become faster and faster. You can have start hesitation and then fascination, so it's harder to take that first dose. And many times that can be caused by low levels of dopamine. So if you're peaking and troughing, and you're wearing off a lot, that can lead to freezing of gait, it can lead to fascination, and it can lead to start hesitation. So the more we can eliminate those peaks and troughs during the day, the less of those off symptoms that you have. Again, doing things like big and loud, so retraining the brain to do the big movements and do the arm swing and the big stride length also helps you with freezing of gait and the fascination. So one would be to tweak the medicines and put you on longer acting medicines so that you have less off periods, and then doing things like physical therapy in the big and loud program to give you a long stride length and bilateral arm swing so that you're swinging the arms to help with the balance. If you're having morning off, then using once a day medicines also helps with that so that you don't start off the day, that first part with the start hesitation and the fascinating gait. Again, using things like the U-step walker and the laser line will help you going through elevators, doorways, escalators to prevent as much of the fascinating gait as possible.
My husband is 78, and he's been diagnosed with Parkinson's about 3 years ago. He has a great deal of osteoarthritis in his back and hips, and it's prevented him from doing the activity that we know he should. He has seen a pain doctor, they've done a nerve block, they've done injections. Any suggestions about, he just seems to have gone in a circle with any kind of, he wants that to get to the place where he can be more active because he knows that's important.
So the question is, we know that exercise is important in Parkinson's disease, but what do you do if you're, now getting up in years and you have a lot of arthritis, and that arthritis prevents you from getting a lot of the exercise? So one thing that you could do is do your exercises in the pool. So things like water aerobics are a good way to get a full range of motions, get some resistance training, without putting a lot of stress on the big joints and making arthritis in the hips and knees and shoulders worse. So water aerobics is a way to get around that if if the steroid injections or the chicken comb things aren't working. Water aerobics is the way to do it.
We have a small pool in our backyard which is heated with solar, and we've got a heater. So he's done that, and still we're not getting the results that he would like to have.
So many times you could use a heated pool in the hospitals, have a heated, like rehab hospitals or the YMCA, so they would allow you to exercise throughout the year, including the winter months when your own pool might be too cold.
Well, we have a cover and solar and the heat, so we usually use between 86 and 90 is what we, both my daughters have rheumatoid arthritis, so we're kind of familiar with using water as a therapy. Yeah, but thank you for your, and the other question I had, what experience have you had with service dogs helping Parkinson's patients?
So the question is about service dogs and using them in Parkinson's disease. And it's not very common, but sometimes you can get them and have them help you, especially with the start hesitation and the freezing of gait. So the problem is getting them trained. That's the biggest problem. But certainly if you can train your dog, then they can help you with the freezing of gait and with walking. But you just want to make sure you have a trained dog, so you don't want a dog that's actually pulling you and causing falls.
This neurology magazine just a month ago listed some special places that they do train, and so we were interested in pursuing that.
Yeah, so if you can get one, it's always good to have a furry friend.
Dr. Ospina,
This lady was waiting.
my husband has had a lot more problems with the non-motor symptoms than the motor symptoms. And one aspect is that I can't find any information about his weight loss. He's lost about 35 pounds in 3 years. he was checked out with GI, to make sure there was no cancer or anything. And he eats almost as well as he did before the Parkinson's. And it's depressing to him to see his body shrink to the point. So I wondered if you'd run into this.
So the question's about weight loss and Parkinson's disease. And weight loss is common in Parkinson's disease for several reasons. One, the medicine causes nausea, so patients don't feel like eating a lot. Two, it takes a long time to chew the food and swallow the food. And many times people have trouble swallowing, so they are afraid of eating a lot. And they don't eat as many calories as they used to because it just takes too long to get through the meal. And then they produce less saliva because the medicine causes dry mouth, so it's harder to start breaking down the starches of the food. You're constipated, so one more reason why you don't feel like you want to eat a whole bunch of food if you feel like you're always full. So many times you're also burning more calories than you're taking in. So if you have a tremor, you have rigidity, or you have dyskinesia, you're burning more calories throughout the day than you're usually taking in, and all of those things can lead to weight loss. So one way to go around that is to use Ensure or Boost or Carnation to try to get all the calories you need, the vitamins and minerals, without having to chew your way through whole sort of steak and potatoes. And then many patients also, they lose their sense of smell. Without smell, you don't have taste, so they're left with sweet and sour, and they develop a sweet tooth. So it's one more reason they don't want to eat a well-balanced meal. So you can take the Ensure, put some scoops of ice cream and some fruit in there for some fiber, and that way you can supplement so that you don't fall behind in your calorie count, and then that leads to the weight loss.
Okay, there's nothing interesting. He's eating pretty much as much as he used to. That's why I'm puzzled by this. I just wondered if there was anything about the disease itself that would...
Yeah, so that you're burning more calories, so that even though you were eating what you ate 10 years ago, but you've got a little engine that's burning the calories with either a tremor or a dyskinesia or just the rigidity. If your muscles are stiff and rigid, they're burning more calories than if you're sitting there relaxed. So even though you were eating just what you were eating before, you're burning more calories.
I just wanted to tell people that there is an organization in town that will help you train your own dog.
Oh, what's the name
You
of
get a
it?
dog about a year old and you take it to Handy Dogs.
Oh, so there's somebody here in town called Hana Dogs that will train your dog. I would make
They
use
help
of it.
you train your dog.
Oh, you train your dog. And how long, is there a waiting list or?
I trained my dog and it took me a year and a half. It shouldn't take that long.
Okay. So there is a place here in town that will help you train your own dog as a service dog.
My question is regarding medical marijuana. Some states allow the use of marijuana to treat patients that have tremors. I'm just wondering what the position is on that.
So the question is about medical marijuana, and Arizona is one of the states where you can get medical marijuana prescribed. There's really no data in the treatment of Parkinson's disease and the use of marijuana, but you can certainly try it and see if it helps you with anxiety and the tremor. Remember that you are taking medicines that are already psychoactive, so that you're more likely to have confusion and or hallucinations with the marijuana, but like any other medicine, you try it, and if it works, keep it. If it doesn't, you get rid of it. So the other thing to remember is that the marijuana you're now getting prescribed is a lot stronger than what you took when you in the 60s and 70s. So it's much more potent. And that when you get a dose, one cookie or whatever the gummy bear is or the lollipop, that is one dose. So you don't take 3 cookies, because that's triple the dose, and then there's an ER visit. Which is bad. Well, I mean, as a Parkinson's patient, you want to stay away from hospitals and ERs, because many times they make you worse, not better. So many times they give you things like Compazine or Phenergan for nausea that blocks dopamine, then you get agitated, and then you get Haldol, which further blocks dopamine, and then they call us and say, Mrs. X is here in the rehab after her hip replacement and she's not able to participate in her physical therapy, and it turns out that you're not getting your cinnamon on time and you're on all of these medicines that block dopamine.
What is the experience with Namenda, and does Namenda have any down points?
So the question's about Namenda. Namenda is a medicine used for dementia and for memory problems in both Parkinson's disease and Alzheimer's. So remember that dementia is part of the non-motor symptoms of Parkinson's disease, and that is made worse by the medicines, not better. There are medicines called Namenda, Aricept, and Exelon that slow down the progression of dementia, but it doesn't stop or reverse the dementia. So many times we'll use it. Some patients will find that they're a little bit more alert and have better word finding, improvement in that sort of thing. But it's not medicine that will stop or reverse the cognitive decline. So that the family members and the neurologist may not notice a big difference, but our hope is that over the year's time, that things have slowed down a little bit.
And could we use dual therapy with Azalac or something of that group?
Yes, so many times we actually use Namenda as an adjunct to Aricept or Exelon, and we add it along with the rest of your Parkinson's medicine. So you could take Azalac and both Aricept and Namenda or any of your other PD medicines along with it. Namenda is much better tolerated than the other medicines like Aricept and Exelon, so it doesn't cause the nausea or diarrhea that the other medicines do. So it's fairly well tolerated, and we usually use both of the combination of both of those medicines. And then with Azalac, what you may notice is that it flags on your pharmacist's computer, not with Namenda, but with antidepressants. So if you're taking antidepressants and Azalac, the computer will flag it and your pharmacist may say, oh, you're not supposed to be on Celexa or Lexapro and Azalac, but it's an MAOB, not an MAOA inhibitor, so you can take both of them together. Usually the only antidepressants we switch you out of are Prozac and Luvox because they're long-acting antidepressants, but otherwise it should not be a problem. But it'll be in the computer forever, so it'll always flag.
And the side effect is you experience oral tongue, speech.
What's side effect?
Oral problems with the tongue moving and the speech affected.
So the question's about, side effects of the medicine and oral movement. So certainly you can have dyskinetic movements that involve the tongue and the lips and the jaw. So just like you can have movements of the arms and the legs, oral or what we call tardive dyskinesia can be common, and we can reduce that by reducing the medicines or switching them to longer acting forms of medicines. So we can have both peak dose dyskinesia, which is too much medicine, and diphasic dyskinesia, which means at the end of the dose you get the wiggly movements. And that can be anywhere in the body, including the tongue and the mouth.
On the same view, how about people who have a tremendous amount of drooling?
So the question's about drooling. So remember, you actually are producing less saliva than you used to before Parkinson's, both from the disease itself and the medicines that you take tend to dry out the mouth. But what you're not doing is you're not swallowing as often as you used to, just like you don't blink as often as you used to. The eyes dry out and get itchy, and you don't swallow as often as you used to, so the saliva tends to pool and then drool out. So just like we want you to blink more often, we lubricate the eyes to make them more comfortable. Then we want to automatically get you to swallow, so we can either have you chew some sugarless gum or suck on a hard candy, and that automatically gets you to swallow and takes care of the drooling. It turns out that many of the drugs that we use to dry out the secretions to prevent the drooling also cause urinary retention and confusion, so many times their side effects are worse than the actual drooling. Then we can also Botox your submandibular glands. But one, it's painful, it's expensive, and then the body's smart and decides, hey, these submandibulars aren't doing their job, we'll get the parotids to produce more saliva, and then we're back to square one. So the easiest, cheapest thing is to suck on hard candy or chew some sugarless gum, and then at night to put a towel over your pillow to take care of the drooling.
There's been recent research about macular degeneration related by I was wondering, I have is there some link because of the dopamine demonstrating Parkinson's? I was trying to figure more about the development.
So the question is about macular degeneration and Parkinson's disease, and they're actually using Cinemet as a treatment for macular degeneration. So remember that Parkinson's has to do with dopamine-producing cells deep in the brain, and you've got some dopamine-producing cells in the retina. So we don't know what it's probably a genetic, so those cells are very similar genetically, but we don't know what the mechanism is, and it's not like melanoma, that patients who have Parkinson's disease have a higher incidence of melanoma. I'm not sure what the incidence of macular degeneration, and would that be higher in Parkinson's or not. But today, now they're using Cinemet as one of the treatments for macular degeneration. So it most likely has to do with the way those cells are constructed and the genetics behind those cells.
In terms of antidepressants, I've been on antidepressants because of familial antidepressant for umpteen years, but I'm finding that they don't seem to be working as well. I'm going to be seeing them in a couple of weeks, and I'm wondering, I've been reading a lot, and it seems as if maybe some of the antidepressants are better for helping with more dopamine, and others are more serotonin.
So the question about depression and Parkinson's disease, remember that depression is one of the non-motor symptoms of Parkinson's disease and can be present 5-10 years before your diagnosis of Parkinson's, just like restless legs, constipation, and a lack of sense of smell. So many times, treating the Parkinson's will also improve the depression, but many times we have to use antidepressants in concert with your PD drugs. So in Parkinson's, your levels of dopamine are low, we give you Cinemet, and that replaces the dopamine, but low dopamine causes low norepinephrine and serotonin, and so many times we need to use another agent like Effexor or Lexapro to increase your levels of serotonin and norepinephrine. So we use both of those things together. So remember, we have to treat the whole patient. Just dialing out the tremor with meds doesn't really do anything to improve your quality of life if you're still too depressed to get out of the house. So that we have to treat the whole patient, both the motor and non-motor symptoms.
Is that hard to adjust?
So it's always a balancing act throughout the whole treatment of Parkinson's disease.